Maxillofacial trauma. Today's lecture. Pathophysiology. High impact supraorbital rim, 200G symphysis of the mandible, 100G frontal, 100G angle of the mandible, 70G. Low impact zygoma, 50G nasal bone, 30G. Etiology. 60% of patients with facial trauma have multi-system trauma and the potential for airway compromise. 2% concurrent brain injury, 4% cervical spine injuries. Blindness occurs in 3%. And emergency management, airway control. Control airway, chin lift, jaw thrust, oropharyngeal suctioning, manually move the tongue forward, maintain cervical immobilization. Avoid nasotracheal intubation, nasocranial intubation, nasal hemorrhage. Avoid repeat sequence intubation, fail to intubate or ventilate. Consider an awake intubation, sedate with benzodiazepines. Consider fiber optic intubation if available. Alternatives include percutaneous, transcranial ventilation, and retrograde intubation. Be prepared for cricotirotomy. Emergency management, hemorrhage control, maxillofacial bleeding, direct pressure, avoid blind jumping in wounds, nasal bleeding, direct pressure, anterior and posterior packing, pharyngeal bleeding, packing of the pharynx around each tube. History, obtain a history from the patient's witness and or ENS. Ample history, specific questions. Was the lock? If so, how long? How is your vision? Hearing problems. Specific questions. Is there pain with eye movement? Are there areas of numbness or tingling on your face? Is the patient able to bear down without any pain? Is the pain with moving the jaw? Physical examination, inspection of the face for asymmetry, inspect open wounds or foraging buds, palpate the entire face, suborbital and infraorbital rim, zygomatic frontal suture, zygomatic arches. Physical examination, check facial stability, inspect the teeth for malocclusion, bleeding, and step off. Intraoral examination, manipulation of each tooth, check for laterians, stress the mandible, tongue blood test, palpate the mandible for tendon swelling and step off. Physical check visual acuity, check pupils for roundness and recurvativity, examine their eyelids for lacerations, test extraocular muscles, palpate around the enteral orbits. Examine the cornea for abrasions and lacerations. Examine the anterior chamber for blood or hip hemorrhage. Perform fundoscopic exam and examine the posterior chamber and the retina. Examine and palpate the exterior iris. Examine the canals. Check the nerve distribution of the suborbital, infraorbital, interior alveolar and mental nerves. Results from a direct blow to the frontal bone with blunt object associated with intracranial injuries of the orbital roof, dual tears. Frontal sinus bone fractures, clinical findings, distribution of screpitine orbital rims, subcutaneous emphysema associated with lacration. Radiograph spatial view should include waters, Caldwell and lateral projections. Caldwell view best evaluates the anterior wall fractures. Frontal sinus bone fractures diagnosis, cut the head with bone windows, frontal sinus fractures, orbital rim and nasopharyngeal fractures, brain injuries of the incranial bleeds. Patients with depressed skull fractures or with posterior wall involvement, ENT or neurosurgery consultation, admission, IV antibiotics, tetanus. Patients with isolated anterior wall fractures, non-displaced fractures can be treated outpatient after consultation with neurosurgery. Associated with the intracranial injuries, orbital roof fractures, dural teeth, mucophyseal, epidural empyema, GSP leaks, meningitis. Nasoetymodal orbital fracture, fractures that extend into the nose through the etymol bones, associated with lacrimal description and dural tears. Suspect is if there is trauma to the nose of medial orbit, patients complain of pain on eye movement. Nasoetymodal orbital fractures, clinical findings, flattened nasal bridge or saddle head shaped deformity of the nose, widening of the nasal bridge, angiosperm, rhinophae or epistaxis, tendons, crepitus, and mobility of the nasal complex, intranasal palpations, reverse movement of the medial canthus. Imaging studies, plain radiographs or insensitive, CT of the face with coronal cut through the medial orbits, treatment, maxillofacial consultation, antibiotic. Nasal fractures, most common of all facial fractures. Injuries may occur to our surrounding bony structures. Three types: depressed, lateral displaced, non-displaced. Nasal fractures. Ask the patient how you haven't broken your nose before. How does your nose look to you? Are you having trouble breathing? Nasal fractures, clinical findings, nasal deformity, edema and tenderness, is epistaxis, crepitus, and mobility. Nasal fractures diagnosis, history and physical exam, lateral or Waters view to confirm your diagnosis. Nasal fractures treatment, control epistaxis, drain special hematomas, refer patients of ENT our outpatient. Orbital blunt fractures, blow of the fractures are the most common. Acute when the globe systems are direct blunt force. Two methods, mechanism of injury, blunt trauma to globe, direct blow to the intraorbital rim. Orbital blunt fractures. Periorbital tendons, swelling, phomocytal, enophthalmos or sunken eyes, impaired ocular motility, infraorbital anesthesia, step of the deformity. Orbital blood fractures, imaging studies, radiographs, Henning tear, drop sign, open bomb bay door, air fluid levels, orbital emphysema. CT of orbits details the orbital fractures, excludes retrobular hemorrhage, CT had intraocular injuries. Blow of the fractures without eye injury, not fragrance admission, maxillofacial and ophthalmology consultation, tetanus, degengescence for 3 days, prophylactic antibiotics, avoid Valsalva or nose blowing. Patients with serious eye injuries should be admitted to ophthalmological service for further care. Zygoma fractures. The zygoma has two major components: zygomatic arch, zygomatic body. Blunt trauma most common cause. Two types of fractures can occur: arch fracture, tripod fracture. Zygoma arch fractures can fracture two or three places along the arch, lateral to each end of the arch. Fractures in the middle of the arch. Patients usually present with pain on opening the mouth. Zygoma arch fractures. Clinical findings: palpable bony defects over the arch, depressed cheek with tendons, pain in the cheek and jaw movement, limited mandibular movement. Zygoma arch fractures imaging studies and treatment. Radiographic imaging submental view. Treatment: consult maxillofacial surgeon, eyes and anesthesia, possible open elevation. Zygoma tripod fractures. Tripod fractures consist of fractures in through zygomatic arch, zygomatic frontal suture, interorbital rim, and floor. Zygoma tripod fractures. Clinical features: periorbital edema and ecchymosis, hypoesthesia of the infraorbital nerve, palpation may reveal step off, concomitant globe injuries are common. Zygoma tripod fractures imaging studies, radiographic imaging, water, submental and Caldwell views, coral kit of the facial bones, 3D reconstruction. Zygoma tripod fractures treatment: non-displaced fractures without eye involvement, eyes and analgesia, delayed operative consideration 5-7 days, decongestants, broad spectrum antibiotics, tetanus. Displaced tripod fractures usually require admission for open reduction and internal fixation. Maxilla fractures, high energy injuries, impact to 100 times the force of gravity is required. Patients often have significant multi-system trauma classified as Lector fractures. Lector first definition: horizontal fractures of the maxilla of the level of the nasal fossa. A low motion of the maxilla while the nasal bridge remains stable. Clinical findings: facial edema, malocclusion of the teeth, motion of the maxilla while the nasal bridge remains stable. Radiographic findings: fracture line which involves nasal aperture, inferior maxilla, lateral wall of maxilla, kete of the face and heart, coronal cut, 3D reconstruction. The second definition: pyramidal fracture, maxilla, nasal bones, medial aspect of the orbits. Second clinical findings: marked facial edema, nasal flattening, traumatic telecanus, epistaxis of tears, rhinorrhea, movement of the upper jaw and the nose. Radiographic images: fractures involves nasal bones, medial orbit, maxilla sinus, frontal process of the maxilla, kete of the face and head. And the third definition: fractures through maxilla, zygoma, nasal bones, ethmoid bones, base of the skull. The third clinical findings: dish face deformity, epistaxis and GSF rhinorrhea, motions of the maxillar-nasal bones and zygoma, third airway obstruction. Radiographic imaging: fractures through zygoma control suture, zygoma, medial orbital wall, nasal wall, kete face and the head. Treatment: secure and airway, control bleeding, head elevation, 60 degrees, consult with maxillofacial surgeon, consider antibiotics, admission. Mandibular fracture pathophysiology: mandibular fractures are the third most common facial fracture. Results and the falls on the chin account for most of the injuries. Multiple fractures are seen in greater than 50% associated G-spine injuries. Mandibular fractures clinical findings: mandibular pain, malocclusion of the teeth, separation of teeth with intraoral bleeding, inability to full open mouth, preauricular pain with beating, a positive tongue blood test. Mandibular fractures, radiographic panoramic views, non-displaced fractures, analgesics, soft dead, oral surgery repaired in 1-2 days, displaced fractures, open fractures, and fractures with associated dental trauma. Urgent oral surgery consultation of fractures should be treated with antibiotics and tetanus prophylactics. Mandibular dislocation. Causes of mandibular dislocations are blunt trauma, excessive mouth opening, risk factors, weakness of the temporal mandibular ligament, overstretching joint capsule, shallow article imminence, neurologic disease. The mandible can be dislocated anterior 70%, posterior, lateral, superior. Dislocations are mostly bilateral. Mandibular dislocation, posterior dislocation, direct blow to the chin, concluder head is pushed against the mastoid, lateral dislocation associated with a jaw fracture, condylar head is first laterally and superiorly, superior dislocation blow to a partial open mouth, condylar head is for upward. Clinical features: inability to close mouth, pain, facial swelling, physical exam, palpable depression, jaw will dilate away, jaw displaced and anterior. Mandibular dislocation diagnosis history, physical exam, X-ray, CT. Mandibular dislocation treatment, muscle relaxing, analgesic, closed reduction in the emergency room, treatment, oral surgeon consultation, open dislocation, superior, posterior, or lateral dislocations, non-reducible dislocations associated with fractures. Disposition, avoid excessive mouth opening, soft diet, analgesics, oral surgery follow up. Thank you.